Thank you very much. Hi, good afternoon everyone. My name is William. Today I'm going to talk about lipoprotein alpha. So I think Dr. Fauzi has shared two very nice cases about young patients with myocardial infarction. So I'm going to spend the next 12 minutes talking about what lipoprotein A is, why is it a trend, what is the big deal, so what, how do you manage this, and what do the guidelines suggest. So every time I look at, I read the news and I see young patients having a heart attack, I've always wondered how come these young patients, compared to older patients, have the same disease but they come on so much earlier. So in the past we used to blame other things, we're not sure what the cause is, we blame smoking, this and that. But increasingly we know that younger patients tend to have something different compared to older patients. So what exactly is lipoprotein A? So if you look at this picture, you can see, I'm not sure if you're a Star Wars fan, but if you recognize this villain, this is Darth Vader. And so I always tell my patients that Darth Vader is a bad guy, but if Darth Vader has a red lightsaber, he's an even more bad guy, he's a more bad villain. So that's what LP-little a is about. So LDL is the little particle on the left, so it has an ApoB100 moiety that causes arteriosclerosis. But LP-little a has an extra ApoA component that is determined by the Kringle segments that we showed with a little tail there, that actually makes the LDL particle more arteriogenic. So if you talk about cholesterol, there's actually a wide range of cholesterol. So we have cholesterols ranging from HDL, VLDL, IDL, LDL, and in a subset of the LDL, the low density lipoprotein, we are talking about one that's particularly evil, the lipoprotein A. So LPA is arteriogenic, pro-thrombotic, and pro-inflammatory. So LPA is produced in the liver and has two main components that's joined by this disulfide bond. You just remember that LP-little a is a worser form of the LDL because of the ApoA moiety. So not only does it cause arteriosclerosis, so it causes plaque formation like what LDL does, but on top of that, because of the ApoA component, it results in increased thrombosis because it's a mimicker to plasminogen. So that causes a double whammy effect. You have a patient, you have this moiety that causes plaque, but this thing also causes pro-thrombosis in patients. And on top of that, they are pro-inflammatory. So if you were to compare an LDL molecule to an LPA molecule, the effect of LDL is still more significant because there is more LDL component compared to LPA, but if you compare 1 to 1, an LPA particle is actually 6 times more arteriogenic than an LDL molecule. So this is a summary slide that tells you the bad effects of the LPA. So it is number 1, pro-inflammatory, it causes a graded inflammatory response in the vessel. It is pro-arteriogenic, and on top of that is pro-thrombotic. So this really is a 3-in-1 particle that has a more potential deleterious effect on the vessels causing plaque. So when we talk about risk factors for developing ASCVD, we divide it into modifiable and non-modifiable. So LP-little a elevation is a non-modifiable risk factor to ASCVD, and this structure is actually genetically determined. So what this means is that this is a number that is not really affected by the environment, that's actually determined by every individual. So it's very unique and customized to each of us. And what makes it genetically determined is actually the concentration of the ApoA component based on the number of Kringle subsets that you have. In summary, just remember that LP-little a is genetically determined. And there's some factors that do affect the LPA levels. For example, the recent infection, presence of autoimmune diseases, kidney disease, liver disease, and CKD. But by and large, this test should be done when the patient is not having an acute infection and the patient is relatively stable. Now this is important to note that statins does not really affect the LP-little a. So in Dr. Fauzi's first case, we see a young man with very high dose of statins, very impressive, atorvastatin 80 and ezetimibe. But despite that, and despite having LDL level of 1.0, he still has recurrent events, and it's only when Dr. Fauzi picked up the elevated LPA and started giving targeted therapy that reduces LP-little a, thus his risk finally goes down. So this is very important. A lot of patients think that they are on high dose of statins, they are not affected, but if the LP-little a is high, they have a high residual risk. So the LP-little a is also quite consistent throughout life, meaning to say that if you were to test it in the teenage years compared to adult, it's more or less the same. And this elevated LPA does affect not only myocardial infarction, it also affects the presence of aortic valve stenosis, stroke, peripheral artery disease, heart failure, and overall mortality. So this is from the UK Biobank. You can see very nicely that once a patient goes above the age of 40, the risk of death or ASCVD is stratified based on the level of LP(a). So if you have an LP(a) of 7 compared to 150, your risk increases with time. What's important to note from this slide is also the unit. So a lot of people remember the number, but they get confused by the unit. So there's a milligram per deciliter versus the nanomoles per liter. So by right, we're not supposed to convert, but the ballpark is 2.5 times the value. So for example, if your lab doesn't do nanomoles, you can more or less like 7 times 2.5 to get 16, but it's not that accurate. Most guidelines prefer to use the nanomoles per liter as the units to trend this LP(a). So it's estimated that about a sixth of the world population have elevated LPA. In Singapore, we are practiced about 20% of patients have elevated LPA. That means that 1 in 5 patients that you are treating actually have this hidden risk that you or the patient may not be aware of, and that potentials to events later on in life. If we were to look at aortic valve stenosis, ischemic stroke, myocardial infarction, and heart failure, you can see very nicely from the graph on the right side that your risk increases with your higher level of LP(a). Now, what about the presence of plaque and LP(a)? You can see very nicely on the graph on the left that if you had an elevated LPA in the presence of plaque, the risk of myocardial infarction is very significant. This is also, you can see on the right side, that this is also true for the presence of aortic valve stenosis. So I'm just going to skip this in the interest of time and go straight to this. So this is kind of like a summary slide. Just remember that LP(a) is genetically determined, and the genetics of it determines the level of the clinical subunits that forms the ApoA tail. And that leads to arteriosclerosis, thrombosis, and aortic valve calcification. So, to illustrate my point, I want to show this video because I always believe that imagery gives a stronger memory effect. So imagine you're in a coronary vessel and this Darth Vader is trying to do damage. So this is actually what's happening in your coronary vessel. LDL together with LP(a) elevation is causing a lot of destruction in your coronary vessels that results in increased arteriosclerosis. Okay, so what do the guidelines suggest? So the guidelines suggest a level of 50 milligram per deciliter or 125 nanomoles per liter as being significant. So this is what I was trying to say earlier on, that there's a difference between the two units, milligram per deciliter versus nanomoles per liter. This is from the 2022 EAS consensus statement of LP(a). So they recommend that it should be checked at least once in a adult. And when you see a patient has an elevated LP(a), what this means to you is that you have to be more aggressive in trying to lower the patient's residual risk. So unfortunately, we do not have targeted therapy to LP(a), at least not yet in the year 2025. It's all upcoming. But what the statement suggests is that if a patient is elevated LP(a), you will want to intensify the LDL targets by having a lower target to what we've already set for the patient. So for example, if the patient had a plaque or an ACS event, and you want to target the LDL level of 1.4, if the patient also has an elevated LP(a), you might want to target a lower target of 1.0 to offset the increased risk from elevated LPA. And they postulated that the reduction in LP(a) may cause further risk reduction in MACE. Now this is all hypothesis generating because we don't have the data results out yet, but it will be out in the future. So LP(a) is now being targeted as a new pathway to target. So there are new drugs that's coming in the horizon. So like Vader and Olpasiran is coming out. I think we are waiting very anxiously and excitedly for the good results that will be published maybe this year or the following year. So in summary, LP(a) is arteriogenic, arterial thrombosis, and causes inflammation. When you have a patient with elevated LDL and LPA, this is a double whammy effect. Always think of elevated LP(a) in your patients who present with ASCVD. This is genetically determined, so there are no targeted therapies yet. So what you do is that you intensify the LDL lowering based on the increased risk for LPA, and there are no targeted therapies in the horizon. With that, I come to the end of the talk. Thank you very much for your kind attention.
Thank you.